Evaluation of infertile couple. This will be spoken by Dr. Ishraka Saeed Ahmad Ibrahim. She's working as a specialist in the Department of Obs and Gynae, Sultan Hospital, Salalah. She did a Bachelor of Medicine and Surgery from Khartoum University, Sudan. She did her DAO, that's Diploma in Obstetrics and Women's Health from Ireland. She is a focal point for ERAS, that's Enhanced Recovery After Surgery, for a department. Recently, she has appeared for Part 3 MRCOG. Here comes Dr. Ishraka.
Good morning, everyone. My talk will be today about the basic evaluation of the infertile couple. My objective will be definition of the infertility, causes in the male and female, and evaluation of the couple. To start with definition, what is infertility? It's the inability to conceive after 1 year of regular unprotected vaginal intercourse, and it is rarely absolute, so the term subfertility may be more appropriate. Fecundability means probability of conceiving in one menstrual cycle. It is between 20 and 35% maximum. Understanding fertility. What we need: a reserve of eggs in the ovaries, healthy egg released on a regular basis, healthy motile sperms in good numbers, opportunity for the egg and sperm to meet, fertilization of the egg by the sperm, and healthy receptive uterus. Main events necessary for pregnancy to occur is ovulation, fertilization, and implantation. Of course, for fertilization, we need a healthy tube where fertilization will occur. Overview of causes of infertility. Around 40% will be a male factor, 40% will be a female factor, 10% will be combined factor, male and female, and 10% will be unexplained, where the all parameters are normal. Main causes of infertility: volume of semen, motility of the sperm, erectile dysfunction, structural defect, obstruction in the genital tract, and sperm count. Can be categorized to pre-testicular causes, testicular, and post-testicular. Pre-testicular can be from the hypothalamus, from the pituitary, central defect. Testicular can be gonadal failure, genital problems, trauma or surgery. Post-testicular can be disorders of transport of the semen, congenital bilateral absence of path difference, infection, and also can be psychogenic. Female causes we can categorize as ovarian, tubal, uterine, and problems in the cervix. Anovulation, tubal factor, uterine factor, or cervical factor. Ovulatory dysfunction around 30%. Can be hypogonadotrophic, hypoestrogenic, central defect. Can be normogonadotrophic, normoestrogenic, or can be hypergonadotrophic, hypoestrogenic. Problems in the ovaries. Can be tubal around 20%, like when there is pelvic inflammatory disease, endometriosis, previous pelvic surgery, previous ectopic pregnancy, all this will affect the tube. Uterine abnormalities in around 15% can be polyps, submucosal fibroids, or adhesions, intrauterine adhesions. Why to evaluate? We evaluate to identify potentially correctable conditions, to identify irreversible conditions that are amenable to artificial reproductive technique using the sperm of the male partner, or to identify irreversible conditions that are not amenable to ART, for which donor insemination or adoption are possible options. Earlier evaluation, we can go for earlier evaluation as early as 6 months. If there is history of prior infertility, if there is presence of obvious risk factor, like the woman has polycystic ovary syndrome, known case of endometriosis, she has irregular cycle, that means she's not ovulating properly, or there is a history of previous chemotherapy or cancer treatment, or the woman aged more than 35. In this condition, we go for early evaluation. Most important is the first consultation. Couples who experience problems with conceiving should be seen together, because both they are being affected by decisions surrounding investigation and treatment, and also should be offered counseling to help them with the psychological stress, as it is a stressful journey. We will counsel them and inform them that the chance of conception around 80% in the first year, providing that the woman age is less than 40 years, no contraception use, and they have regular intercourse. With intrauterine insemination, 50% will conceive within 6 cycles, 75% will conceive after further 6 cycles. We also will counsel them and inform them about the period of maximum fertility. It is around the time of ovulation, 6 days before and up to the day of ovulation. Basic evaluation, history examination, history pertaining to all above-mentioned causes, husband semen analysis, test for ovulation, test for tubal latency, and transvaginal scan. Coming to history, history will highlight where the cause could be, and preferentially those causes to be evaluated first. We start with the duration of infertility, for how long they were trying, and whether it is primary or secondary, whether she mother a baby or he father a baby. We also start with the duration of fertility, because the longer the duration of infertility, lesser the chance of successful conception. Couples with less than 3 years of infertility, they stand a better chance of pregnancy. Coming to the age, it is the most important determinant of fertility, especially in the female partner. Female fertility starts to decline from 30 years, more steeply from 35 years. Women between 19 and 26 years have double the chance of conception than women 35 to 39 years of age. Also, male fertility decline after 50 years, and sperm chromosomal abnormality also will happen after this age. We have also to inquire about the frequency of the sexual intercourse, and it normally or usually will be every 2 to 3 days to achieve the conception. Sexual history will ask any difficulty during intercourse or any sexual dysfunction. For the female partner, also careful menstrual history, whether she had regular periods or not, the amount of the bleeding, any pain with period, dysmenorrhea, any dyspareunia, any pelvic pain, any sexually shared infections, or any history of pelvic inflammatory disease, or any symptom signs of thyroid problem, or any galactorrhea. Drug history for both couple, any use of cimetidine, anabolic steroids, spironolactone, chemotherapy or radiotherapy, or over-the-counter and recreational drugs. Chronic illness also can affect the fertility. We ask for tuberculosis, diabetes, renal disease, liver disease, multiple sclerosis, or spinal cord injury. Surgical history will ask about any history of orthodopexy, vasectomy, inguinal hernia repair, scrotal or urethral surgery, and in the female, any pelvic surgery or any pelvic surgery in the tubes and ovaries or the uterus. History of smoking and alcohol is important as it decreases the count and motility, and people who are smoking, they take longer to conceive. Also, occupation is important, like exposure to heat, toxins, and radiation. Tight scrotal support and family history of infertility, also important. Coming to the examination, BMI, the most important, less than 19, underweight or more than 30. Women with BMI of 30 or more or over likely to take longer to conceive. Coming to the examination of the female partner, we look for thyroid enlargement, angularity, tenderness, any breast secretions and their character, any signs of androgen excess, like acne, hirsutism, examination of the cervix, secretions, any signs of infections, uterus size, whether it is anteverted or fixed retroverted uterus, adnexal mass or tenderness, and cul-de-sac mass. Examination of the male partner, we look for the BMI, secondary sexual characteristic, hair distribution, muscle build, examination of the testis and scrotum, antecedent testicles, abnormal mass or scrotal skin changes. Check for epididymis, swelling or congestion, whether there is varicocele, hypospadias or epispadias, any discharge, and digital examination of the inguinal area. The primary test, semen analysis. The collection of the sample should be after abstinence of more than 3 days and less than 7 days. Collection will be in the laboratory. Masturbation sample at in sterile container. These are the normal parameters, and this is the recent WHO 2021 criteria 6th edition. If we compare with 2010, only slight difference in the volume and the motility. Most important in the semen parameter are the morphology and motility. Morphology reflects capacity of the sperm to fertilize the egg. If we have one or more abnormal semen parameters, we refer the male partner to be evaluated by a male reproductive expert for complete history, physical examination, and for other directive tests if indicated. Computer-assisted semen analysis, it has advantage of being more objective and reproducible measurement, superior documentation of laboratory values, superior in measurement of sperm motility. If no sperm, we can reveal the test earlier, and we have to check the validity of the test. If no sperm, azoospermia, we can evaluate by doing the hormone test, the gonadotropin and the testosterone. And if gonadotropins are high, low testosterone means there is gonadal failure. If all normal hormones mean there is obstruction, and if low gonadotropin and testosterone means there is hypogonadotrophic hypogonadism, central defect. Coming to the female, tests for ovulation. If the female had regular monthly menstrual cycle, that's likely to be ovulatory. So we can look for other factors like tube and uterus. We do day 21 serum progesterone if the cycle is 28 days. Women with irregular cycles offer the test depending on the time of the menstrual cycle. They may need to conduct later in the cycle, like day 28 if the cycle is 25 days, and repeat weekly thereafter till next cycle starts. If more than 10 nanogram per ml, it correlates well with normal endometrial storage. Progesterone, it starts to increase after the ovulation and indeed at day 21 if it is 28-day cycle. Cervical mucus changes. Around the ovulation, the cervical mucus becomes thin, stretchable, spin parquet, and if spread on a slide, give the firm infertile. Like in the first 3 days, it will be dry. After that, it will become sticky. Then it will become cloudy, creamy, and around the ovulation, it will become stretchy and slippery. For ovulation also, we monitor the follicles with transvaginal scan. Follicular monitoring will be done, and it grows 2 millimeters per day. It reaches 20-26 mm, and also we can see the endometrial thickness. We can use this to monitor the treatment if we are giving ovulation induction, and also to assess the growth of the endometrium. For ovulation, also we can use the urinary luteinizing hormone test. These kits are available. Can use luteinizing hormone increase just before the ovulation. We can use utility for timing of the intercourse. Can be used to time the intercourse, but it's not very sensitive, and it can give obsession with the timing of the intercourse. Basal body temperature, 3 to 4 days after the ovulation, temperature will increase due to progesterone on 4.5 Fahrenheit and with a comparison test. Coming to ovarian reserve, it gives an idea of the potential of the ovaries to respond to stimulation. It does not predict the chance of having a baby. Total antral follicles measured by transvaginal scan on day 3 of the cycle. If it is less than 4, it will predict low response. If more than 16, predict high response. And poor ovarian reserve testing does not necessarily imply an inability to conceive. Ovarian reserve also will check for the anti-malarial hormone and the FSH level. And increasing age, there will be drop in the antral follicle, anti-malarial hormone, increasing the FSH. Tests for uterine factors. Women not known to have any comorbidity. They don't have any previous pelvic infection, any previous ectopic, not known to have endometriosis or no previous surgery. For these women, we can do ultrasound scan, transvaginal, 2D or 3D. We can see if any fibroids, uterine polyps, any ovarian cysts, or any anomalies. Also, hysterosalpingography. It is done in the follicular phase, day 5 to day 11 of the cycle. It will show the size, shape of the uterine cavity and any developmental abnormality. It is less invasive, more efficient use of resources. Saline infusion sonography. It's effective alternative to HSG if no comorbidities. No radiation, assess the uterus and the tubes, diagnose polyps, submucous fibroids, synetia. It is not reproducible and it needs experienced operator than the standard hysterosalpingography. It will show the uterine cavity, synetia, any polyp, submucous fibroid will be detected. Evaluation of the fallopian tubes. If no comorbidity, also no previous surgery, no pelvic infection, we can use for the evaluation of the tube also the hysterosalpingograph, and it will show tubal occlusion, whether it is proximal or distal, any hydrosalpinx, fimbrial phimosis, or peritubular adhesions. Also for the tubal vacancy, we can use saline infusion sonography. Laparoscopy and dye test should only be performed after complete investigations. It's not a routine test. It is indicated in young women with abnormal HSG or non-comorbidity, like non-pelvic infection, endometriosis, or previous surgery. It is an invasive test, requires admission and theater setting. It evaluates the fallopian tubes, ovaries, tube-ovarian relationship, and pelvic peritoneum. You can see the dye spill from the tubes. Can also be used as a therapeutic modality for lysis of adhesions, excision and treatment of endometriosis, can be used for ovarian drilling and cystectomy, tubal reconstructive surgery. So tubal and other pelvic pathology can be assessed at the same setting. Adhesiolysis can be done. And also, if the adhesions are not extensive. We know periadnexal adhesions impairs the tubal motility and the ovum pickup. Other tests, if indicated, like hysteroscopy, for we can see the emiseptum, intrauterine septum, polyp, or cervical stenosis. Can also be there for diagnostic and therapeutic. Tests which are not correlated with pregnancy, postcoital test, anti-sperm antibodies, thyroid function test, only if symptoms of thyroid problem. What can be done to boost the fertility? Knowing that many factors are out of control, like age, some other factors can be controlled, like to keep BMI, BMI between 19 to 25, stop smoking, alcohol, drugs, frequency of intercourse every 2 to 3 days, and timing best time before the ovulation. Other checks important: folic acid, 0.4 milligram daily, rubella vaccine, vitamin D 10 microgram, and control any pre-existing medical condition before trying for a pregnancy. In conclusion, the chance of conception is affected by factors in the man and the woman, as well as frequency and timing of intercourse. Age is precious. Right evaluation gives best outcome. It is a good opportunity to consider the overall health, treat all comorbidities to get a healthy pregnancy and healthy baby.
Thank you, Dr. Ishaq, for a beautiful presentation.